Hi everyone, good morning. MSN, new topic, nephrotic syndrome. Now, when I say nephrotic syndrome is a word coined from two Greek words. Okay, nephrosis means kidney, syndrome means a group of signs and symptoms. Okay, so you understood the definition? Not definition, it's introduction. Nephrotic syndrome. Fine. So, moving on to the definition, it's a collection of symptoms. I said syndrome means group of signs and symptoms, right? So it's a collection of symptoms, okay, which is resulting in the damage of the glomeruli, capillary membrane of the kidney, okay. When it is damaging, protein is going through urine, loss of protein, okay, which is ending up in kidney problem or kidney diseases. Fine. This is nephrotic syndrome, okay. Now, when I say loss of protein, henceforth I will be saying proteinuria, means protein is going through urine, proteinuria, okay, or hypoalbuminemia. Fine. Now what are the signs and symptoms? Sorry, not signs and symptoms, etiology. Now, what can be the causes that can affect nephrotic syndrome? It can mostly be because of diabetic mellitus, hyper BP or high BP, hypertension. Okay, then low immunity patients such as HIV, HBsAg, hepatitis B, malaria. Okay, then risk of infective patients like low immunity patients will be there, or else if the person is having any cardiac problem, okay, like pericarditis and all, this syndrome is most usually seen it for them. Okay, moving on to the pathophysiology. Please listen, pathophysiology is important. Okay, so as we discussed, due to etiological factor, there is a damage in the glomeruli membrane. Okay, when the damage occur, protein is loss of protein or loss of albumin. Fine. Now, from there, the pathophysiology is dividing into two. Okay, I repeat, due to etiological factor, uh, glomerular membrane is getting damaged. When the glomerular membrane is getting damaged, protein, loss of protein. From there, the pathophysiology is dividing into two. One is hyperlipidemia, one is hypoalbuminemia. Okay, hyperlipidemia, one is hypoalbuminemia. Fine. Hyperlipidemia ends up in edema. Hyperlipidemia ends up in edema. That's it. This area is closed. Fine. Now, this area, hypoalbuminemia. Okay, hypoalbuminemia, because of that there will be decreased oncotic pressure. Okay, decreased oncotic pressure. When this pressure is decreasing, kidney automatically secretes a enzyme called as renin. Okay, activation of renin automatically from our body. Okay, so when the kidney is when the renin is secreted, what happens is like renin produce angiotensin 1. Okay, now angiotensin 1 cannot stand or cannot do anything alone. So what angiotensin 1 will do is that angiotensin 1 will be getting converted into angiotensin 2 with the help of ACE, that is angiotensin converting enzyme. Okay, when it is getting converted to angiotensin 2 release aldosterone. Okay, when aldosterone is reduced, BP will increase, or in other word we can say sodium retention. Okay, when BP will increase, edema. Understood pathophysiology? I'll repeat once again, don't confuse yourself. Due to etiological factor, okay, damage to the glomerular capillary membrane. Okay, from there protein loss is happening. From there, pathophysiology is getting divided into two. One side is hyperlipidemia, one side is hypoalbuminemia. Okay, hyperlipidemia means increased lipid, okay, in blood or fat content in blood. So when hyperlipidemia ends up in edema, this part is closed. Okay, here hypoalbuminemia, decrease albumin in blood. Okay, so when hypoalbuminemia I say, what happens is like it ends up in decreased oncotic pressure. When the pressure in the kidney or the oncotic pressure is decreased, kidney automatically secrete renin. Okay, when renin is secreted, renin secrete angiotensin 1. Okay, angiotensin 1 cannot do anything alone, so angiotensin 1 can get converted to angiotensin 2 with the help of ACE, angiotensin converting enzyme. Okay, angiotensin 2 again secretes aldosterone. Okay, aldosterone, what do aldosterone do is like it increase the BP. When the BP is increased, swelling or swelling or edema occurs. Okay, this you will be seeing in through the help of adrenal gland. In endocrine system, I think so you might have learned this, right? So I hope pathophysiology is understood. A little bit confusing, but if you focus, you'll understand. Fine. So I said edema or swelling. Edema or swelling. See, in this nephrotic symptom, edema will be like two types. Edema is of two types. Okay, pitting edema or non-pitting edema. Pitting edema means, suppose if I have a swelling here, okay, or if I have edema here, if I press, it is going down. That means it is pitting edema. Okay, it is pitting edema. Or else if it is like that only, it's like if you are pressing also, it's not going down. Okay, that means it is non-pitting edema. Fine. So moving on to the diagnostic evaluation. Diagnostic evaluation, history collection, physical examination, urine test will be done, blood test will be done, especially RFT, KFT. KFT will be done. Okay. Then test X-ray, because pericarditis is a cause. Fine. So diagnostic evaluation is over. Moving on to the clinical manifestation. Clinical manifestation, person will be having oliguria. Oliguria means less than 400 ml of urine per day. That is oliguria. Oliguria. Okay. Then dysuria, hypertension, fever will be there for the patient. Okay. Then hematuria, anorexia. I hope you know what is anorexia, right? Then shortness of breath, breathing difficulty will be there, swelling will be there for the patient, pain will be there, fatigue will be there. Okay, oliguria will be there for the patient, dysuria, hematuria. Okay, so this is all about the clinical manifestation. Moving on to the management. See, now what happened? What management you will give? We can give ACE inhibitor. ACE inhibitor, that is angiotensin converting enzyme inhibitor. Why? Because in the pathophysiology, ACE is converting angiotensin 2, right? So when you inhibit, inhibition means suppress it. Okay, so ACE inhibitor we can give. For example, an alpril we can give. Okay, then we can give anticoagulants. Okay, then any hypertensive medications can be given, diuretics can be given for the patient, because the patient is having swelling, right? Lasix, furosemide and all. Fine. So this was all about nephrotic syndrome. I hope you all understood. Okay, just brush up. Nephrotic syndrome is signs and symptoms. Okay, a group of signs and symptoms that is affecting the glomeruli. Through that, it's resulting in the loss of protein. Okay, etiology, diabetic mellitus, hypertension. Okay, or we can say it as pericarditis. Low immunodeficiency patients will be having nephrotic syndrome. Pathophysiology, due to etiological factor, glomerular membrane is getting damaged. When the glomerular membrane is getting damaged, protein loss happens. Through protein loss, pathophysiology dividing into two: hyperlipidemia, hypoalbuminemia. Okay, hyperlipidemia ending up in edema. Hypoalbuminemia, decreased oncotic pressure. When the oncotic pressure is decreased, renin gets secreted. Renin produces angiotensin 1. Angiotensin 1 gets converted into angiotensin 2 with the help of angiotensin converting enzyme. Angiotensin 2 release aldosterone. Aldosterone increase BP or sodium retention, edema. Fine. Clinical manifestation: main oliguria, hematuria, dysuria. Okay. Then shortness of breath, edema, fatigue, fever. Okay. Management. Diagnostic evaluation, history collection, physical examination, urine test, blood test, especially in KFT bun. Okay. Then management will be giving anticoagulants will be given, diuretics will be given, ACE inhibitors will be given. Okay. Then we will be advising the patient to loss of protein is going through the body, right? So we will ask the patient to intake protein intake. Okay. Then bland diet, we will be asking the patient, advise the patient to drink more water. Okay. So this is all about nephrotic syndrome. I hope you understood. Bye.